Thank you very much. I'll try to speed up my presentation as much as possible. So we have no disclosures. And what was the aim? To investigate the oncologic outcomes in patients with anastomotic leak after anterior resection for rectal cancer, classified according to the International Study Group of Rectal Cancer Anastomotic Leak Grading System. We all know that anastomotic leak is a severe surgical complication that affects morbidity, mortality, hospital stay cost, functions, and quality of life. And this is associated with adverse oncologic outcomes, although we don't understand exactly the mechanism in all these cases. There are several studies focusing on that, but they all differ for treatment, design, and follow-up, and they mostly differ for definition of what it is an anastomotic leak and the assessment on how to determine if there is an anastomotic leak. In 2010, the ISREC proposed a definition and a clinical grading system for all anastomotic leaks and after anterior resection in order to standardize this. And this is validated now by several studies. And the interesting thing is that they classify grade B and grade C differently, as grade B corresponds to any leak that can be managed by antibiotics or endoluminal therapy, compared to grade C that actually requires redo surgery. It is unclear today if the severity of the anastomotic leak impacts on the long-term survival, and this was our aim. We analyzed retrospectively a prospective database of all consecutive patients undergoing TME or partial EME for rectal cancer between 1998 and 2013. So we have 5 years follow-up today. We excluded metastatic patients, acute bowel obstruction, tumor perforation, synchronous colorectal cancer, and previous history of rectal surgery. We included cases that had neoadjuvant long course chemoradiotherapy for T3, T4, up to N2, but no metastatic, as I said before. They all had an adjuvant chemotherapy within 8 weeks to stage 2 with high risk, or for stage 3 that consisted of 5 fluorouracil and leucovorin till 2004, and after that we routinely added oxaliplatin. The clinical definition was corresponding to fever, peritonitis, bad drainage, but in all cases we confirmed it by a CT scan. And the severity was categorized, as I said before, and only anastomotic leaks requiring antibiotics or reoperation are in this group. We excluded all anastomotic leaks that inadvertently were occasionally found before closing a stoma that are considered grade A. The oncologic outcomes, overall survival, disease-free survival, local and distal recurrences are investigated here. We did a multivariate analysis for factors affecting disease-free survival and overall survival, including subgroup patients with indication for adjuvant therapy. And we also did a multivariate analysis for the factors that affect the adjuvant chemotherapy. We have 532 patients, 42 experienced an event of anastomotic leak, classified 15 as grade B and 24 by grade C. As you see, in the grade B, thanks to the fact that in 2009 we started endovac therapy, not all the treatments were equivalent. Patients' characteristics are absolutely overlapping between the two groups of anastomotic leaks, positive or negative, except for the fact that the adjuvant chemotherapy, of course, was administered in about 50% more of the cases in those that do not have anastomotic leak, of course, as largely expected. Which are the factors that affect the administration of adjuvant chemotherapy? Well, as you see here, no surprise to say that the age was a parameter, the Charleston Comorbidity Index was also a parameter, positive, the surgical approach, and the anastomotic leak itself. But interestingly, as you see, we lose in the multivariate analysis the grade C of the anastomotic leak. So apparently, grade B has a role in the administration of adjuvant therapy, chemotherapy afterwards. Are intraoperative data influencing this? No. Surgical approach doesn't change. Conversion to open surgery doesn't change. Not even the stoma rate changes. It doesn't have an influence even pathology. The positive CRM is the same in the two groups. The pathology stage is the same. The T stage and the lymph nodes harvested are exactly the same, or more or less the same. In any case, not significantly different between anastomotic leaks and non-anastomotic leaks patients. If you look at the data of the anastomotic leaks, you see that there are really overlapping situations between grade B and grade C for gender, age, body mass index, and all the other standard variables that routinely we should determine in such an analysis. But very interestingly, seeking for differences between the two groups, we were able to find that CRP levels, so C-reactive protein levels, differed at 2 weeks after the start of the treatment of the anastomotic leak, either antibiotics or endovac in one case, or reduced surgery in the other case. So I said it again, at 2 weeks, there was a statistically significant difference between grade B and grade C, much in favor of grade C. This was almost 3 times more in grade B, as you see, and the level of CRP was also almost 3 times more at 2 weeks in those that recurred compared to those who did not recur. And this was statistically significant. Now, if we look at the differences in anastomotic leak patients between grade B and grade C, as I said before, there is really no difference for positive serum, for pathology, for T-stage, for lymph node, and also for adjuvant chemotherapy administered or not. So looking at the oncologic outcomes, not surprisingly, we could demonstrate that those patients that leak have a 5-year overall survival rate much worse than the one that do not have an anastomotic leak. And the same goes for disease-free survival. The same goes also for local recurrence, which is about 3 times more often occurring in patients that have a leak, and also for distant metastasis at 5 years. But when we look at the curves, here is the interesting thing. If you look at the 3 curves, the first one is the curve of those who do not have a leak, and the other 2 are grade C and grade B. So it is confirmed that grade C performs better than grade B in the overall survival on the left, as well as in disease-free survival on the right. And if we look at the predictors for that, in the multivariate analysis, as I announced before, you see that there is a clear role of T-staging, of lymph node ratio, of lymphovascular invasion, and of course of anastomotic leak. And if we analyze the subgroup of those patients who should have done adjuvant therapy, you see that this was administered more often in those patients who did not experience the anastomotic leak. And exactly the same analysis goes for the disease-free survival. So in conclusion, this study has huge limitations. It's a retrospective study. It's a single institution study, but it's a very large study. The cohort is of more than 500 patients with a rate of about 8% of events. And everything was reviewed electronically thanks to the fact that we store all these data since then. And the conclusion, I think, are that the anastomotic leak grade B affects the use of adjuvant chemotherapy, but also anastomotic leak grade B is predictor of poor survival unexpectedly in rectal cancer patients. Those patients who receive adjuvant chemotherapy after 8 weeks or do not receive chemotherapy at all have a poorer oncologic outcome. And interestingly, a postoperative systemic inflammation seems to play a role sustained in grade B rather than in grade C, affecting long-term survival. Thank you for your attention.